Thank you, Mary. Great. Thank you guys for having me here today. I'm going to follow Dr. White's lead. I'm going to get off of this thing here and stay away from the speakers. I was warned about that. So, all right. And speaking of great coffee, this place in town called Stumptown, I don't own stock. It's just they have this thing called they put nitrogen in the cold brew pour. It comes like a beer. It is the smoothest coffee. I hope somebody here works for Stumptown. Maybe I'll get a free cup later. It's good stuff. All right. Well, so we'll get slides up shortly, but I'm going to be talking about dyspnea and respiratory difficulties. You guys have all the slides. I'm not going to follow the slides exactly. I'm going to kind of just, like Dr. White, I'm just going to teach. We're going to talk a little bit about these things. And yeah, and hopefully you guys may have some questions later. We'll hit on some highlights and hopefully some good take-home points. For just out of curiosity, just getting to know the audience a little bit here, just show of hands. Nursing tribe, nurses, nurse practitioners, CNS, great. Pharmacists, perchance? Okay, excellent. PAs? Docs? Okay, great. Did I leave anybody? Social workers, maybe? It's probably not a typical, oh, thank you. Okay. Anybody else I left out inadvertently? No? Great, okay. So, dyspnea. So what is it? Anybody? It's after lunch. Work with me a little bit. Yeah, feeling of breathlessness, right? Difficulty breathing, right? So it's a sensation, it's a felt sense of not being able to get air. Patients describe this differently, shortness of breath. I feel like I'm drowning, I can't get enough air, I have a hard time breathing, my chest is tight. Okay, so that is all dyspnea. It's a felt sense. And like pain, it turns out there's really no great way of measuring it. I mean, you know, we do pulse ox, we check people's respiratory rate, of course we listen to them, but those are sort of surrogate markers, right? So at the end of the day, kind of like pain and like nausea, right? The vomiting part we can measure. The nausea part, not so much. So similarly with dyspnea, it's really how the patient is experiencing it, right? Like so many of our patient population, a lot of them have chronic lung disease, right? So they're chronically tachypnic. That's how they live, right? They've adjusted to that. In fact, if you mess with that, this is about the right time of the year in the hospital for somebody, like a friendly neighborhood intern to try to mess with that, right? Bad things happen, right? They're chronically a little hypoxic. That's how they live, right? So they're surrogate markers. The best way to get at it, I do what's called a Borg scale. It's a fancy way of saying 0 to 10, okay? And it's great for tracking people's symptoms. I use this for pain, I use it for nausea, I also use it for dyspnea, okay? So 0 to 10. 0 is how you breathe at your baseline, how you normally are. 10 is, you know, I think I'm gonna die because I just don't feel like I can breathe. That's a 10. Okay. It's pretty straightforward. And like so many of these symptoms, it's sort of how the brain's interpreting this, and we'll talk about this a little bit more, right? So the key here is, you know, reflex, we just put them on oxygen. But as we just talked about so many times for so many of our patients, it's not just that, right? And so it's a complex physiology. We're not going to get into it other than to sort of say that there's a series of stretch receptors, mechanoreceptors, chemoreceptors in your lung, in your bloodstreams, and all this signal gets sent